welcome to the meeting. Yes, over to you, Dr. Alex and Dr. Kaulback.
Good morning, everyone. Thank you for joining this morning. I'm not sure Dr. Kaulback is able to join. He has cases this morning. I had to rearrange a few of my cases so that I can present. I hope you find this case interesting. Just to understand a little bit about our system. So Thomas Jefferson University is kind of like the main hospital, and then we also cover some of the level 2 trauma centers. So this patient initially presented to one of the level 2 trauma centers and then ended up being transferred. He was 19 at that time, 18, but he just turned 19 when he was in the hospital. 19-year-old male, motorcycle accident. He was wearing a helmet. The speed was at least 40, 45 miles per hour. Initially, he was found with jaw deformity, bilateral wrist deformity, a left neck, degloving injury, and diminished breast sounds on the right chest. That was from the field. He did lose consciousness, and his blood pressure was systolic 80s. They placed a C-collar, started him on normal saline via peripheral, and he was brought to the trauma bay. On primary survey, he was found with obvious jaw deformity, which contributed to the decision to intubate him along with the hypotension. Also, he had diminished breast sounds into the right chest, so he at least needed to go and have the soft tissue washed out. His GCS was 13. A point was taken for eyes being closed and the confusion, and on exposure, just abrasion everywhere, the whole body, the degloving neck injury. There was platysma visualized, and he had laceration of the left face and bilateral wrist deformities. In the bay, he was intubated. He got a chest tube that put out 1 liter of blood. He got units of blood, and his pressure settled at 105/78 with a heart rate in the 90s. He got lines, and MTP was activated. He got the tetanus shot. Pelvic X-ray was unremarkable. FAST was reported negative. He had lactic acidosis, a base deficit. Coags were not too far off. Nothing else in terms of secondary survey, past medical surgical history. He did have a scar on the chest, but we weren't able to figure out what happened with him before. And now we're in the scanner. We decided to take him to the scanner since his pressure and heart rate was holding. And we just, the scout was as you see it, and he just started dumping now more blood from the right chest. It was dark venous blood, and he dropped his pressure again, 96/50. And what would you like to do at this time? So options are stop and go to the operating room, or finish the CAT scan. If you go to the operating room, what is your plan? Valeria, if you could help with moderating.
Sure, Dr. Alex, I'll do the moderating today. Thank you.
Oh, thank you. I'm sorry.
So, no problem. Not a problem at all. Okay, so Dr. Ontrack, would you like to make your
yes, yeah. In this case, I would take him right to the operating room. He said the FAST was reportedly negative, but I assume you did it yourself, and that you're comfortable that it's negative. But in this case, because he's pouring dark blood out of the right chest, I would take him straight to the operating room, abort the CT scan, and plan first for a right anterolateral thoracotomy, which you can clamshell to the left side if need be, but I would start right anterolateral thoracotomy and stop the source of the bleeding. That's the likely source of the hypotension and tachycardia, so I would go there.
Okay, thank you, Dr. Ontrack. Dr. Supa, would you like to make your comments now?
I agree with Dr. Ontrack to take this patient to the OR and put him in the supine position. And we can begin with a right anterolateral thoracotomy, as he mentioned. And we can always open the abdomen if we suspect some bleeding going on. But first, I would start with right anterolateral thoracotomy. Thank you.
Thank you, Dr. Supa. Dr. Qasim, would you have any other comments to add?
Well, this patient is hypotensive, but it is not too far from where he came from. And even though his heart rate is in the moderate range of 105 for a 19-year-old, his blood pressure is not that bad. I don't think I would rush him to the operating room at this moment, even though that you see blood pouring out of his right chest tube. I think I would continue with resuscitation and get whatever studies that you were doing and get it completed rather quickly, and then perhaps take him to the operating room. And in the operating room, I would rescan his abdomen to make sure that you are not overlooking abdominal injury, because by and large, chest injuries that causes bleeding, they usually stop, in my opinion. So I would not rush into the chest incision initially. I think I would do a rescanning of it to make sure that I'm not overlooking anything in the abdomen. Thank you.
Thank you, Dr. Qasim. Dr. Namias, would you like to be a panelist today and make some comments?
No, I'm sorry, I can't. I'm on 3 channels right now and heading to the SICU in a few minutes. But I did hear about a ton of blood pouring out and hypotension, so I'm fine with the OR.
Sure. Thank you, Dr. Namias. Dr. Kobi, would you also like to be a panelist today and like to make some comments? Okay, I don't think he's here. Yeah, okay, is he? Yes, please continue, sorry. Okay, can't hear. Okay, Dr. Rodriguez, would you like to make some comments with us today? Doctor, I think you're on mute.
Okay, thank you.
Sure.
There is a role for judgment, you know. By the rules, this patient is hypotensive, is draining more than 1,000 cc from the right for the chest. So you should go where the money is. In this case, the right anterolateral could be correct, you know. But also depends where you are. If you are in the intergalactic or the Miami or the shock trauma, or you have a CT scan 3 feet away from the admitting area, then use patient, I agree, the patient could be stabilized and you can take it in 3 minutes to the CT, and 3 minutes you have a pan CT, Rodrigogram, whatever they call it, okay? And you know everything was going on. But if you are in the regular place, the majority of places the CT is right there, then I agree with it to go to the OR, that where the money is the right chest. But if it is time, be better to know what else is going on, because you find surprises, you know. And by the way, the most common cause of bleeding, massive hemothorax by the book, you know, is intercostal artery bleeding. It's not the aorta, it's not the lungs, it's intercostal artery bleeding.
Thank you, Dr. Rodriguez. Would anybody else like to be a panelist or share comments that I haven't asked yet?
We haven't heard from Doctor in Boston.
Dr. Rahman, Dr. Qasim, he said he also may have cases and he would have to rush.
Sorry.
Yeah, I don't see him on the. Okay. Okay. I think we can go back to Dr. Alex to continue the case presentation. Yeah.
So the operating room, this place is a different floor, but not across the street or like too far off. He was getting blood and he was holding his hemodynamics, and one of the thoughts and the concern was, what if it's something of nature of like liver bleeding into the chest since the blood was so dark? And then he stayed for like a quick run of the CAT scan, and it showed here the extensive soft tissue injury. You can see the gas and the air from the degloving injury. But the CT scan, and now we're seeing some obviously adequately placed right chest tube, retained hemothorax, but now we're seeing these sternal wires. And I told you at the beginning, he had this like scar on his chest, and we weren't sure what the deal was with that scar over there. Because he couldn't tell us because of confusion. The preliminary report after scanning also the abdomen quickly was just right side hemothorax, prior sternotomy wires, and no free fluid or evidence of solid organ injury in the abdomen. So what would you do now? Sternotomy, thoracotomy, or any other incision? We're going to the operating room. This can be, I guess, a quick run through everybody with this information. Would you do sternotomy or would you do right thoracotomy?
Sure. Okay, let's, Dr. Rodriguez, can we start with you? Would you like to answer?
I don't think I don't think anybody will do an sternotomy. If you have an incision and you're going to be scarred there, you're going to kill the patient. Doing the right anterolateral thoracotomy, again, I learned a lesson many times. You go where the money is. The money is bleeding from the right chest. You have to go. I know resuscitation is left anterolateral thoracotomy, is the most versatile incision, but the patient is bleeding from the right chest. That's where you have to go. There's no other option for me.
Okay. Thank you, Dr. Rodriguez. Dr. Supa, would you like to answer the question?
I agree with right anterolateral thoracotomy. Thank you.
Thank you, Dr. Supa. Dr. Antrek?
Yes, so I was cut off for just a minute, but I gather the CT scan showed the bleeding in the right chest. So Dr. Supa has his junior associate there, his junior surgical partner, and he probably asked him for the right answer. So I'm gonna go with that, since he looks like a smart kid, a smart junior surgeon. So very good.
I think that's a good option, Dr. Antrek.
Yes.
Dr. Qasim, would you like to answer the question?
I go with Dr. Rodriguez, who said where the money is. It's called the Willie Sutton law. Willie Sutton was a bank robber. He kept robbing the bank. When asked why he keeps robbing the bank, that is because that's where the money is. So I agree with Dr. Rodriguez. Go with where the money is. Right.
Okay.
I don't like anterolateral thoracotomy. I would like to position him like Dr. Supa has taught me many times, to position him in such a way that I will have access to the abdomen if I need to. So I do a posterolateral. Thank you.
Okay. Thank you, Dr. Qasim. Dr. Alex, I think we can continue with the presentation.
Okay. Thank you. All right, so in the operating room was placed supine. A right anterolateral thoracotomy was performed. There was venous bleeding. It was noted coming from what looked like a tear in the right atrium, kind of close to the appendage. There was definitely a lot of scar tissue, and this was extended into a clamshell because it was noted that the heart was getting into VFib arrest, and the pericardial and pleural adhesions had to do with his prior atrial septal defect repair in childhood, which was reported by his mother when she found out that he's in the hospital, and she provided additional information. So this kind of shows approximately where this was. Of course, this looks good on the, we have a picture of how it looked after it was repaired, but it was kind of hard to discern exactly where, but it was right atrium going down along the auriculum. Let me see if I can advance the slide now. So in the operating room now you have a situation like I just described with approximately 4 centimeter tear. How would you repair it? Or would you get CT surgery to go on bypass? And if the audience can comment, if you have a situation like this where you have a cardiac injury and imminent cardiac arrest with VFib, what's your choice? Would you repair the injury first, then restart the heart, or restart the heart then repair?
Okay, Dr. Qasim, would you like to make your comments first?
Well, in a case like this, the first thing is not to panic. So you have identified the lesion. The first thing I would do is put my finger there, or put a couple of fingers there to stop the bleeding from this hole, and then allow the tank to fill up. And once I've seen the tank is filling up and the bleeding is somewhat controlled, and then I would probably attempt to put a J clamp or something like that, or even a Babcock clamp, 3 of them, to get the edges together so I can stop the bleeding. That would be the key to my success in this case. I think I would try very, very hard to stop the bleeding, whatever maneuver that I'm going to use to stop it. Don't start putting sutures and things like that right from the beginning. I think you will lose if you do that. Thank you.
Thank you, Dr. Qasim. Dr. Rodriguez, would you like to share your views?
First place, I think bad luck with this surgery. I don't think I have been doing trauma surgery for 40 years, and I don't remember having a case post-cardiac. So this guy did something wrong. That was your patient, doctor? You didn't go to church or something, you get this case. It's not an easy case. I mean, somebody who has surgery before pediatric surgery, and you find a scar tissue there, like hell, it was a hell probably to repair it. And the repair of the atrial, if you go to South America, I'm learning something, they use a lot the Foley catheter. I use one time, but because I'm afraid to put the stitches through the Foley balloon, but they use it routinely, successfully. They are so good using Foley catheter and atrial ruptures that I said, God, I mean, I would like to be the guys to do that without hitting the balloon, But normally I would try to put, the doctor says, some hemostat, not traumatic, to hold the atrium toward you, put the Satinsky, perhaps. Depends the size of the rupture, I see you described the size, 10 centimeters, you said?
4 centimeters.
It still is big, and usually I have prepared, and every trauma service should have in the OR, and 3-oproline for the aorta and 4-oproline double arm with pledges already placed. The pledges the cardiac surgeon use was teeny tiny. So I cut my own pledges, big pledges. So I put it and do that way. Now, if it's a stab wound, gunshot wound, you can put a 1 stitch cross and it's okay. But this is blunt trauma and it's 4 centimeters. So you have to use that. We talk about the same technique,
Thank you, Dr. Rodriguez. Dr. Supa, would you like to make your comments?
Yes, in this case, if I have my CPT colleague nearby, I would definitely call the cardiac surgery to come and help, because the patient is, we are doing the redo cardiac surgery. It's going to be difficult. And if I could identify the injury like Dr. Alex showed us right here, the first step is I would try to stop the bleeding before I restart the heart, because I think it would be much more difficult to control this laceration once the heart is restarted. And I saw in the comment, Dr. Camilo said that we could use a Satinsky clamp, and I agree with that for the atrium. You can apply the Satinsky clamp to control the bleeding, and you can use the 4-oproline to quickly run the laceration continuously. And that would be my approach to try to stop the bleeding first and restart the heart later. And using Foley catheter is a good idea if you know how to do it. But in my experience, I always rupture the balloon when I try to suture the laceration. But it's a quick way of bleeding control at the heart of the heart wound. Thank you very much.
Thank you, Dr. Supa. Dr. Antrak, would you like to make your comment?
Yes, I agree with all the comments. I would put either a Satinsky clamp or a series of perhaps 3 Judd Ellis's to stop the bleeding, and then immediately place the intrathoracic paddles to directly defibrillate the heart. You don't want to go too long with the heart in fibrillation because the likelihood of reversing it decreases. But I'd call for the paddles and then the clamps, and then just put the clamps on and then suture it after the heart regains sinus rhythm. This is like, during training, we all spent some time on cardiac surgery. So you open the sternum and cannulate through the right atrium. So it's the same closure of the atrial incision, and you can just control it with clamps, and the heart can start beating again, and it'll work fine. Then you can suture with a beating heart.
Thank you, Dr. Ontrak. Dr. Burke, are you here with us today?
Yes, I am.
Would you like to be a panelist and make some comments?
Sure. I completely agree with Dr. Ontrak. I've fixed something like this in the past, but not in a re-op. But I would suture it with the heart beating with pledgets as discussed.
Thank you, Dr. Burke. Dr. Alex, back to you.
Thanks everyone for your comments and insight. So this is a picture after the repair was done, but as it was mentioned, the friend was the Statinsky clamp. It was not very easy to do open cardiac massage because you can see everything was kind of like stuck around. But from the side, you can see both the blue arrows pointing towards the lung, the green arrow towards where the repair was made. But using the paddles, which were asked for simultaneously, and some intracardiac epi, were able to defibrillate him. And the clamp was left in place. Cardiothoracic surgery came. There was a call placed to cardiothoracic, and the repair was made with fluoroproline running horizontal mattress over pledgets. The pledgets were put underneath the clamp. I have a picture of some, like a schematic, so we better understand. Then the Statinsky clamp was removed, and then the same suture was run back towards where it was started at the top and tied to itself. In the operating room, he required massive resuscitation and transfusion, 45 units of blood, 35 FFP, platelets, cryo. His pH improved to 7.1 from 6.9. The blue arrows point towards the internal memories, which were tied off, and you could see the pledgets with where the scar tissue was, where the tear was, and that basically held in a way that scar tissue was kind of a blessing in disguise. Maybe it prevented that tear to be much bigger and for him to completely exsanguinate, although by the amount of blood product he got, he sort of did. But that's how it looked at the end. Just a couple of slides here. So for exposure to the heart, usually median sternotomy gives you a good visualization of the SVC, aortic arch, pulmonary artery, right atrium, right ventricle, and even intrathoracic IVC or intrapericardial. The left atrium and the left ventricle is also visualized well, and the coronaries, and then bilateral long hilum. But as in our case, and some of you pointed out at the beginning, if start right anterolateral thoracotomy, if you need, you go into a clamshell. And then with the left as well, if you need to see more of the right side of the heart, then a clamshell thoracotomy is your friend, gives you access to the anterior heart, superior mediastinal vessels, both lungs and hilum. You can even look at the back of the heart, but you need to elevate it slowly, either with a stitch at the apex or a Duval clamp, and gently, slowly elevate the heart. You can accomplish that with some laparotomy pads also, but you need to be careful to not cause an inflow occlusion of the heart and then subsequent arrest. So if you have a big hole and everything is kind of happening at the same time, cardiac inflow occlusion, it's a way to diminish a little bit the amount of bleeding from the hole where you are able to repair it, but you definitely need the second good pair of hands. You basically need to find a way to occlude or diminish the flow to the SVC and IVC just enough so you can see better for a few seconds, and just place maybe 1 or 2 sutures with pledgets, and then allow the heart to drink, and then you repeat that. And of course, also you need to consider and keep in mind that, you know, cardiac bypass may be an option. Just really quickly about atrial injury. So atrial wall is very thin, especially the right atrium is like 2 millimeters, the left ventricle a little thicker, but we're talking millimeters here. The finger for control of bleeding and Statinsky clamp, that's what was helpful. So you can see this schematic here, the clamp was kind of angled this way and not involving the coronary. The repair was done with fluoroprolin, but instead of horizontal, so pledgets were placed underneath the clamp, and instead of doing horizontal matters, the cardiothoracic surgeon started up top here, and it was like more like a basting stitch underneath, mimicking a horizontal mattress, and then the Statinsky clamp was taken off and the suture was ran back to the top. Foley balloon is a good option, and staples. I think staples will just definitely tear a thin atrial wall, but this is what was done for this particular case. It's important to stay in very close touch with anesthesia, because high dose pressors are the enemy of repair and sutures and staples for cardiac chamber injury. You know, a high dose of epi or levofed will really make your heart beat like a Ferrari. You know, you don't want that kind of engine. You want something more like a slow diesel type of pump, and you're looking for the long distance, not like a quick strong contraction that will just rip your sutures apart. Additional injuries found after the final reads were out. Basically, the mandible coming on the fracture that needed repair. He had a right internal carotid intimal flap. The soft tissue was in the neck was just washed out, and he didn't need any other intervention. He had some lacerations that were repaired. And he had left scapula fracture, bilateral wrist fracture, a T7 compression fracture. The final read on the scan of the abdomen was that he has questionable lupus small bowel with air fluid level and a small amount of pelvic fluid. So he's transferred to the CQ, given the amount of resuscitation and everything that was done to him, with an open chest, the laparotomy pads, bilateral chest tubes. The skin was partially closed and then IO-band was placed on top. Just quickly for the panelists, how do you plan your second look, and what would you like to do intraoperatively when you take a patient like this back to the operating room?
Thank you, Dr. Alex. Dr. Andrzej, would you like to make your comments?
Yes, certainly. In this case, I'd like to see how he does over the first 1 or 2 days. He was still, said last blood gas pH of 7.1 and lactate, in the 3. So want to see that he's improving and perhaps trying to wake up a little bit if maybe you're keeping him sedated for because the chest is still open, but see how he improves. And then I'd also be concerned about the possible abdominal injury. So if he does show signs of improvement, then before taking him back to close the chest, I would rescan the abdomen to get a sense. If it clearly requires a laparotomy, partial injury that then progresses to clear pneumoperitoneum and more fluid in the pelvis, then I would plan also to do a laparotomy at the same time. And I might want to close the chest first so as not to have an open chest with a potentially contaminated abdomen if you need to go back on the abdomen. So I might consider it that way, that contain the infection in the abdomen, get the chest closed, and then do what you need to do in the abdomen, bowel resection or repair, whatever. But that's the way I would approach it. A day or two, look for physiological recovery, and then go from there.
Thank you, Dr. Ontrak. Dr. Qasim, would you like to make your comments?
I would not rush into doing anything to the chest as long as doing better. I would be very concerned with the finding in the abdomen. You may be very successful in doing a repair in the chest, and then patient may succumb to sepsis from the abdomen. So therefore, I would pay very close attention to what's going on in the abdomen before I do anything to the chest at this moment. I want to make sure that my patient is not hiding anything in the abdomen, and I would not hesitate to go back and have a look in the abdomen to make sure that I have ruled out everything before I take the patient to close the damage control clamshell thoracotomy. Thank you.
Thank you, Dr. Qasim. Dr. Supa, would you like to make any comments?
I agree with leaving the chest open in this patient because he may suffer from a thoracic compartment syndrome if you close the chest incision too tightly. And in my experience, I try not to use excessive negative pressure to suck the fluid out of the chest. I would just connect the two chest tubes to the suction, like minus 20 millimeter mercury. That would be enough. I would not use 100 millimeter of mercury pressure like I use in the abdomen. The heart would not tolerate that. And to go back to the OR, I think we can use the same principle as open abdomen in damage control surgery. Once the physiologic derangements are corrected, you can take the patient back maybe a day or two. And I agree with Dr. Untrak to have low threshold to open the abdomen in this patient. If we are suspecting injury in the abdomen on the second operation, I would do the laparotomy to rule that out first. Actually, I agree with Dr. Untrak to finish everything in the chest, try to remove the packing and close the chest incision. And then we can reassess the abdomen and we may do the laparotomy later to avoid contamination to the chest. If the patient is observable 1 or 2 days, you can check for signs of peritonitis or signs of sepsis. And if the patient is stable enough, re-scanning the patient is good idea also. Thank you very much.
Thank you, Dr. Supa, for that insight. Dr. Burke, would you like to make your comments now?
Yeah, I missed a little bit of what the CT the abdomen showed, but if there's some question about whether he perforated his jejunum or there's some leak, small bowel injuries, airflow. All right. Are they calling that free air, or is that's just an air fluid level?
It was not called free air, but
injury.
It was
a
questionable small bowel injury, clinical correlate.
Yeah,
I mean, looking a little different than the rest of the loops of the small bowel.
Sure. Yeah, again, if there's a hole in the intestine, resuscitation is not going to proceed well. So you'd be stuck going to the OR. I think I would probably, I assume he's got an NG tube down, although I don't see it. I think I'd put contrast down the NG tube and scan him while you're trying to get his coags back to normal and or close to normal and warming him up. And if there's a leak of contrast, you'd have to go back to the OR and close his chest and explore his abdomen. Maybe sooner than you probably would if you knew there was nothing going on in his abdomen. If that doesn't sound too convoluted, obviously a very difficult situation.
Thank you, Dr. Burke. Dr. Rodriguez?
Yeah, probably because of my 80 years old Alzheimer, I miss the the reason why you left open the chest. And now I realize you did a clamshell. I missed that too, because I thought you were just describing clamshell. And I had to make some comments about clamshell. In 40 years of trauma, I have done 2 clamshells. Why? Because I thought it was it's not easy. It's not, however, again, we have a course which is the most magnificent course on technical surgical techniques. It's called DQT for the Pan American Trauma. We are translated to English so you can enjoy it, okay? And the Latinos love clamshell. They do once a week. They are good doing clamshells. I said, well, I don't think we need all the time clamshell. In this case, apparently it was necessary, right, Dr. Alex? Because it doesn't seem you were able to fix the atrium just with the right anterolateral thoracotomy. I assume that was the reason why you do clamshell. Because clamshell, you have to cut the mammaries, you have to have somebody who retract upward, and the old day we have a medical student for 2 hours holding the clam, whatever, the shell, and it was difficult. So I don't know, everybody thought, oh yeah, we do a clamshell. I asked, how many clamshell you have done? I know many big trauma surgeons who have done not many either, okay? So I don't know how, it's very popular to say because it sounds very good, clamshell. But in this case, I guess it was necessary. So one commentary, to call a cardiac surgeon. I did cardiac surgery for 2 years, part of my training after doing a fellowship in trauma. And when I stayed where they did also a little trauma, the cardiac surgeon knew trauma because that was Detroit Receiving Hospital, okay? But most of the cardiac surgeons, with all respect, and I'm a cardiac surgeon training, I never did after training, you know. I don't know if I trust them, unless you never have suture a heart or something like that. In this case, they did this running suture and all this stuff. You know, they have to justify that you called in at 3 o'clock in the morning, you know, but I don't think that was necessary, okay? So don't call them unless you need it. You need it, call somebody, okay? But, and the other thing is, you mentioned a very interesting part technique. When you have injury to the ventricle, you want to lift the ventricle up, that you learn as a cardiac surgeon, and do not just lift the ventricle up, because you're going to go, a patient go in VTAC, okay? Or if he was coming out from VTAC, going back to VTAC. You have to do what you said. You have to put some packs and slowly lift it up, gently. That's a very important point, that we kill patients sometimes trying to be seeing if there's another hole in the back of the heart, and they say, let me see it. You lift the tip of the heart and the patient going in cardiac arrest. So you have to do it slowly, that's lifting up. If there is a hole in the back of the heart, you already told the nurse to have ready you 4-op Prolene, 3-op Prolene, SM needle, double arm, ready to put one stitch, drop the heart, and then put the second stitch, lift it, drop the heart, and then tie. So no doing all the time suture at the same time, because the heart will not tolerate that. That's a technique that you mentioned more or less, Dr. Alex, so I think was very important to know. So I didn't know. Now, you were so concerned, I missed again, that you said there was fluid in the belly, or you're concerned that with bowel injury. You know, if you're, again, I'm learning from the Latin Americans who are very aggressive trauma surgeons. They're very good, I tell you. They probably tell you, no, if I have any concern, after I take care of the chest, I can put the laparoscope, and they, in 15 minutes, they can even run the bowel and tell you there is nothing injury, there isn't, you open, you know, and don't have to open the belly completely. I don't know. I was before the era of the Chinese stick surgeons, the laparoscopic surgeons.
Thank you, Dr. Rodriguez, for that insight. Dr. Alex, I think back to you.
Thank you for the comments and the insight. So he shows signs that he's improving in the ICU. He's moving all extremities, not so much the left upper extremity, but he had a scapula fracture there. His ABG is improving. He's not on high settings. He's on just a low dose Levofed. His lactic acid is trending in the right direction, coming from 8.5 down to 2.5. He had an NG2 for the questionable finding on the CT scan. He had acute kidney injury, and his creatinine was slowly creeping up, but he was making adequate urine output. He required more platelets, but otherwise INR and coagulopathy resolved. He continued antibiotics. You can see on the right side of the screen the list of consultants that were seeing him, and we took him back, and packings from the chest were removed. He had bilateral chest tubes placed. The chest was closed with sternal wires and the number 1 vicryl. The abdomen, Dr. Rodriguez, yeah, we could have stuck a scope, but we were worried that if we insufflate, we're gonna put more pressure from the abdomen and affect his hemodynamics. So just a mini laparotomy was performed, and everything looked fine. Small bowel, we did not scan him because we worried about his kidney function. So we just went straight with a upper midline laparotomy. The neck was washed out again, and interrupted stitches were placed for some of the lacerations. But TE was discussed, but it was not performed, just to kind of look at the heart and pressures and everything. But given the significantly fractured mandible and the maxilla, decision was to kind of hold off and not do it because of how he was doing hemodynamically, and everything looked pretty good otherwise. So first week in the ICU, he was on full dose aspirin. He had an MRI of the C and T spine, showed ligamentous injury, and the T7 vertebral body fracture. So and TLSO was recommended. He needed tracheostomy and PEG tube placement given the amount of work that had to be done for the mandible. His first week was just high fever. He had all the fever workup, which ended up being negative. We also did a HIDA scan because his LFTs were up, but it was shock-lived. We want to make sure his gallbladder is not a problem given pressors and whatnot. But ended up settling down with a small dose of Toradol, so it's probably Dressler syndrome. A week later, he went to the operating room for a trach and a PEG, and then maxillofacial worked on his mandible. This is a 3D recon after the repair, which was quite extensive with a lot of plates and screws. The rest of the hospital course was unremarkable. We did a repeat CTA at the neck just to make sure his healing the common carotid, the internal carotid blunt injury. And he actually started moving his left upper extremity. We were thinking maybe he needs an MRI of the left brachial plexus, but it was not needed. It was definitely due to the pain he experienced from the fracture. He did well with ventilator wean, chest tubes were removed, 2 feeds were at goal, and 3 weeks later he went to rehab. He was seen not too long ago, actually mid-July. Follow-up visit, he still has the splints on the trach in place. Currently, I heard he's decannulated and the PEG tube is out. So at this point, I would welcome any final thoughts and comments. With regards to pericardial window fast, I know we take it with a grain of salt if there is a left pleural effusion. Should we do the same in the setting of maybe somebody who has a prior cardiac surgery where you have adhesions and you may not see what you need to see? Sternotomy versus clamshell, in terms of somebody who had a prior sternotomy with wires in place. You know, I'm curious what your thoughts are. And with regards to closure of the clamshell thoracotomy, we put above and below where the sternum was transected, and single wire, and we use that to kind of anchor it and make it like a cage. And then we use Vicryl if there are any other thoughts or suggestions or other ways of doing it from the panelists. Thank you.
Thank you, Dr. Alex. That was a really, really interesting case. Dr. Qasim, would you like to make any final comments? I think you've muted yourself, Dr. Qasim.
I said, my goodness, Alex, I'm glad I woke up this morning to listen to you. So this is a fabulous case, a very educational case, and I learned a lot of stuff here. So the first thing I learned was, when you see a patient in trauma bay with a previous chest incision or sternotomy or wires, pay attention to that, because this may come back to bite you. The second thing is employing a clamshell incision in a situation like this. Like Dr. Rodriguez says, perhaps not my cup of tea. And again, I know I have not done too many clamshell incisions in my career, which is now in the 40th year. And I prefer median sternotomy, or I prefer posterolateral thoracotomy incision. I think I'm glad that you employed mini laparotomy instead of laparoscopy. As soon as you do laparoscopy in a case like this, you will immediately have a 30% loss of cardiac output, and that is not going to be very good for the patient. So be aware of that too. And the last thing is, I think it was very well managed case, and I learned a lot of stuff from you today, Alex. Thank you so much.
Thank you.
Thank you, Dr. Qasim. Dr. Supa, would you like to make your final comments and thoughts?
Thank you, Dr. Alex, for presenting this interesting case. For your questions, pericardial window fast, I think it's not accurate for detecting cardiac injury if you have a hemothorax, because the bleeding may decompress into the hemithorax. That's why you cannot see the pericardial blood. And I think also that previous cardiac surgery and adhesion will make this test less reliable. And for incision to repair the heart in this patient, I think we have to use right thoracotomy because the indication was right hemothorax. And I think using thoracotomy first is safer than go straight to sternotomy in the patient with previous cardiac surgery, because at least you're gonna go into the virgin cavity. And if I have to do sternotomy in trauma patient, I think I would call cardiac surgeon to help. And I closed the clamshell thoracotomy the same fashion that you did. Sternum, I use wire, and for ribs, I use Vicryl 1.0. Thank you very much.
Thank you, Dr. Supa. Dr. Rodriguez, would you like to make any final comments?
Alex, excellent case, excellent management. And I think it was interesting to discuss all these techniques, including the clamshell, which I think is a good transition, but you have to have some experience doing that, and is it is good. It's good. I think the case was done correctly. Somebody who have different ideas about what to do, but even the suture. I went to a conference in Latin America where the most famous trauma surgeon in this country, books, etc., who he said he repaired the ventricle with 4-O-Prolene. I said, excuse me? 4-O-Prolene to repair the ventricle. You had to know, ask the nurse what you want. You had to have, in this case, 4-O-Prolene was the adequate suture, and the type of needle, you had to say SH needle, what you need to repair the atrium. You just, the scrub nurse tells you, what do you want, doctor? You had to know exactly what you need. You had to be prepared to know what you need. But don't use 4-O-Prolene to repair the ventricle, because it's 6-O-Prolene, because 6-O-Prolene is suture to repair coronaries. But you can write book, but it doesn't mean you know what the hell you're doing. Thank you.
Thank you, Dr. Rodriguez. Dr. Untrak, would you like to make your final comments and thoughts?
Yes, so masterful management of a case, clearly one for the major leagues and not one for the level 2 trauma center, clearly one for the for Jeff or similar facility. And somebody that's had a median sternotomy and in a case of trauma, to go back in a redo, it can be really nightmarish, and you might actually cause more damage and more injuries and more holes in the heart or enlarge this one. So I think, starting in an area, virgin area, and then extending it just a short distance across the area of the former operation, I think that actually was beneficial in this case. And in fact, probably this kind of an injury, this blunt hole in the atrium might have been caused by the adhesions that he had, just tethered one portion of the heart and the rest of the heart was able to move. Just like when you get an aortic laceration by the same mechanism, probably that made it more likely in this case. But I think, it would have been very difficult, I think, to open up a sternotomy as a redo. So I think it was to your benefit doing it this way. And I think you chose that way not to do a sternotomy because of the scar, and I think that was a good choice. But very well done. Very well done, Dr. Alex.
Thank you, Dr. Ontrak. Dr. Weatherly, do you have a question for Dr. Alex?
Hi, not doctor, paramedic. I'm a critical care medic, and we use field expedient ultrasound, which would have instantly caught the buildup of fluids. And I just wanted to know if Dr. Alex, from a pre-hospital standpoint, would have been appropriate for chest tubes in the field.
I don't think his issue was, ventilation and oxygenation, and I don't know. Depends on the transport. Like if you're looking at having to bring somebody, a longer distance, then you can, put a chest tube and auto transfuse if you really can do that. If you have to fly somebody like this, then you may need to put a chest tube. Just kind of see how much and quantify the blood loss. And if you have hemothorax, then you want to make sure if you're airlifted that you don't get a pneumo that's biting you as volume expands with change in pressure at same temperature, the Boyle's law. I hope this answers. Thank you.
I don't think there was an indication for putting, the reason for chest tubes in this case was for massive hemothorax and shock. So to put a chest tube for massive hemothorax to decompress the chest, I don't think. I agree with Alex that there will be no indication in this case. One thing is for tension, pneumothorax or something. In those cases, they put needles, and that's kind of what I scare because I have seen putting needles in the field and stool coming out because they hit the column. So be careful.
Thank you, Dr. Alex and Dr. Rodriguez. Dr. Kobe, do you have a question for Dr. Alex?
Yes, thank you, Dr. Alex. The great case and well researched. I have just two questions. How long is his cardiac arrest?
Seconds. The fact that we were able to just get into his heart never stopped. It was just fibrillating, drop his pressure, clamp, volume was given, paddles, and just gently massage it from the outside. The hands could not go around all the entire heart because of the adhesions there, but it never stopped. It was fibrillating and dropped the pressure. And then intracardiac epi and paddles brought it back.
Okay, lucky he is. And the next question, how long does it take for prior surgery?
Cardiac surgery?
Yes.
They were there very quickly. I would say half an hour they were there.
Oh, great.
When the call was put into them, they responded, yeah.
Okay. So next question, okay? Okay, so if you have no cardiac thoracic surgeons, will trauma surgeon proceed the cardiac surgery?
So the question is, if there's no cardiac surgeon, how would I have repaired this?
So yes, so if you are trauma
legit sutures and trioprolin or foroprolin on an SH needle.
Okay, so you trauma surgeons manage a cardiac injury.
Yes, that's what we would have. That's what I would have done.
Okay, thank you.
Thank you, Dr. Kobe and Dr. Alex, for answering his questions. Dr. Burke, would you like to make any final comments?
Yeah, that was an amazing outcome. The prior chest surgery made it, a nightmare. I definitely wouldn't have done a median sternotomy. I would have worried about cutting the phrenic nerves and other type things that would have resulted in a disaster. The clamshell, it gives you great exposure. It gives you at least two cavities that haven't been operated on before. The mediastinum, obviously, you're gonna have scar. And then closing it, I would have closed it just like you described, as best you could, trying not to hit anything vital with a stitch at the sternum.
Thank you, Dr. Burke. Hi, Dr. Martos. Would you like to make the final comments?
Yeah, I would just like to say thank you very much for Alex for presenting this very interesting case. I would like to acknowledge, I need to acknowledge Dr. Smith for Dr. Aurelio Rodriguez. For the ones that don't know, I think everybody knows, but he's the founder of the Pan American Trauma Society. He's our mentor. And Dr. Rodriguez, I think you are very proud to see today your society having reaching Iraq, Japan, Thailand, you see. So I think this is part of our dreams coming true. You are a society of nice people, good surgeons, friends, and that's one of the goals that you achieve to provide knowledge, education throughout the Americas and now throughout the world. So thanks for joining. It's always a pleasure, honor to have you join these meetings. As you can see, you have a lot of good cases, a lot of young people, young faculty growing in our society. I think this guarantees that a great future for our society. Thank you for joining, Dr. Rodriguez. And again, everybody remember, please try to contact Valeria and Maya and Patricia to schedule a presentation for the next few weeks. We like to have like 80 weeks in advance of the full calendar, so they need to keep calling you for cases in 1 week short notice. And everybody remember, you're going to have a Congress in Cartagena in the first week of November. It'll be very nice to see everybody in presence over there, not only through the camera. Thank you, Dr. Rodriguez. Please make a summary of the case and the teaching points for the case, and you end the conference, please.
It was really an honor to be with you guys, and I enjoy very much Alex and all the commentators. This is very interesting because we all have some experience and we can exchange. That's the idea of the Pan American, exchange ideas, exchange our knowledge, okay? No, we don't, one person don't know everything, you know? But what's great, the presentation and all the commentators were excellent. Congratulations, we'll continue like this.
Thank you. So see you all next week. And thank you, Valeria, Patricia, Maya, for making this happen.